Hello everyone, welcome to Patho Excellence. In this lymph node cytology video series, today we are going to discuss the monotonous large cell pattern. In previous videos, we have discussed monotonous small and intermediate cell pattern. Now, in this topic, we will discuss what exactly the definition of monotonous large cell pattern and what are the different entities which can show this large cell pattern. So, by definition, smear shows more than 50% large lymphoid cells and background shows very few small mature lymphocytes, and often more than 80% of large cells seen in highly monomorphic cases. Now, what is the cell size criteria? So, large lymphocytes which is more than 20 micrometer in diameter and it is approximately 2.5 to 3 centimeter, 3 times size of small lymphocyte, and it appears slightly larger in Romanovsky or Adrite smears and slightly smaller in PAP or HNE and cell block. So, nuclear features if we compare, so nucleus is more than or equal to size of histiocytes nuclear size, and it is having vesicular chromatin, prominent nucleoli, regular nuclear contour depending upon the entity, and background shows scattered small lymphocytes and it may give a clean but monotonous look. Now, diagnostic implication if we see, it suggests high grade lymphoid neoplasms, especially DLBCL, immunoblastic lymphoma and Burkitt lymphoma if we can find extremely uniform and presence of vacuoles. So, let us see all the entities one by one. Most common is DLBCL and its variants. So, this is accounts for 25 to 40% adult lymphomas. Old age patients are mostly seen with this type of DLBCL lymphoma. It is presented as rapidly enlarging lymph node and mostly around 40% case show extranodal involvement. Transformation is very important because this is generally arise from, one is chronic lymphocytic leukemia or small lymphocytic lymphoma which is transformed into Richter transformation. Second, follicular lymphoma transformation into DLBCL, and third is marginal zone lymphoma. So, core features include it is having highly cellular smears, 50 to 80% cells are of large lymphoid size and background shows histiocytes and scattered small lymphocytes, and most important is it is having fragile cytoplasm. So, abundant number of lymphoglandular bodies along with the naked nuclei are visible. So, there are three types of cytomorphological variants of DLBCL. First is centroblastic, which is most common, and here you will find medium large cells and having vesicular chromatin, 2 to 4 peripheral nucleoli and mild irregularity with presence or absence of cleaves, and it may show vacuolization. Second is immunoblastic, which is having very poor prognosis. It shows very large cells, prominent centrally present nucleolus, basophilic cytoplasm and plasmacytoid differentiation. Third is anaplastic, as the name suggests, it shows marked pleomorphism. It may resemble to Ritz-Sternberg like cells or anaplastic large cell lymphoma, and sometimes it can mimic metastatic carcinoma. So, here in this smear you can see these are the large cells, neoplastic cells having large nucleus with abundant blue cytoplasm, and some of these cells show plasmacytoid appearance with perinuclear HOF, and you can see prominent nucleoli in these cells. So this is diffuse large cell B lymphoma. Another smear here shows centroplastic cytology, where you can find, this is the pap smear. So here you can identify nuclear feature in a better way. Here you can see large cells with large nucleus, prominent multiple nucleoli and abundant cytoplasm. Here again centroplastic cytology, where these neoplastic cells show having, if you compare the these large neoplastic cells with the lymphocytes, this is having 2 to 3 times uh, enlargement than lymphocytes. So this is large neoplastic cells. If you compare with the lymphocytes, you can appreciate 2 to 3 times enlargement. With irregular nuclear membrane, some of having elongated nuclei and some of having deep cleaves. So this is again a centroplastic cytology, and prominent nucleoli are visible in almost all of the cells. This is again a DLBCL showing prominent cytoplasmic vacuolization, as well as these are the lymphoglandular bodies which also shows vacuolization. This is immunoblastic variant and showing plasmacytoid differentiation. You can see peripherally placed nucleus, abundant cytoplasm, prominent nucleolus centrally placed, and uh, having look like plasma cells. So it is plasmacytoid appearance, and all cells are larger than the small lymphocytes, and they are having almost 3 times large size. This is anaplastic variant. As the name suggests, very high grade and pleomorphic cells. So this is very large pleomorphic cells in DLBCL category. These are also neoplastic cells, but this is a anaplastic cell. Now background, if we see lymphoglandular bodies, which gives a clue to lymphoma, frequent mitosis and apoptotic bodies are seen. Sometimes extensive necrosis may be seen, but here because of crush artifact, there is prominence of naked nuclei which having clumping effect, and it may mimic small cell carcinoma, and sometimes false cluster may give appearance of metastatic like look. So here we must know immunophenotype before stamp it as a DLBCL. So here it is positive for CD19, 20, 22, 79A, which is pan B cell marker, also PAX5 and CD45, and variants include CD5 positivity in around 10% cases, which is of de novo subtype, and CD30 positivity in anaplastic variant. And there are two subtypes like germinal center B cell and activated B cell. So germinal center B cell are arising from centroblastic cells having better prognosis, while ABC, which is activated B cells, arising from immunoblastic origin. So it is having poor prognosis. Here we have to correlate with hence IHC algorithm. We will see in next slide. Now cytogenetics, mostly 30% cases show BCL6, which is 3q27, BCL2 T1418 in 20 to 30% cases, and MYC which is in aggressive or borderline with Burkitt lymphoma. Now this is again we can have a confusion if we see this type of molding effect with the small cell carcinoma. So here we can see this malignant or neoplastic cells are showing or they are without cytoplasm. So these are the all naked nuclei clumped together and having a molding effect, but this is a case of DLBCL. Here again we can see this large cells which are having clustering effect, and some of the cells are having intact cytoplasm, and it may mimic metastatic malignancy. But in all these cases, IHC is must on cell block. Here again, background shows necrosis, and some necrotic debris is present. Some of the cells show pycnotic nuclei, and some of the naked nuclei are also seen. But we can appreciate large size on the basis of comparison with these small lymphocytic cells. This is a mitosis, and some of the apoptotic bodies may be seen, but here it is not visible. But you can appreciate these are the angulated nuclei, some of having nose like protrusion, and this is again a DLBCL. Now, what is Hans algorithm? Whenever we see all these type of features, we have to go for IHC, and to classify on the basis of this Hans algorithm, we require CD10, BCL6 and MUM1. So, on the basis of this, GCB or germinal center B like or non-GCB, which is activated B cell like ABC, we can differentiate. This classification has a prognostic significance and sometimes therapeutic implication. So, first of all, what we have to do, we will go for CD10 marker. If it shows positivity in more than 30% of cells, the interpretation is this is the GCB subtype. Now suppose if it is negative, then go for BCL6 marker. If it is negative, no GC differentiation, so this is non-GCB or activated B cell like or ABC type, right? Now suppose if it is positive, then go for MUM1. So if MUM1 is positive, which shows post GC activation, and it suggests non-GCB or ABC subtype. And if MUM1 is negative, that means retain GC phenotype, and this is germinal center B cell like subtype. So this is how Hans algorithm is used for DLBCL. Now what are the diagnostic pitfalls? So first of all, flow cytometry. In 15 to 25% cases, it can be falsely negative. Reason behind that is these cells are very fragile, and they get destroyed while processing. So, forward scattergram and side scattergram plot lacks larger cells, which is a clue when we see flow cytometry or when we interpret flow cytometry. So what is the solution? Again, the morphology, which is gold standard, and second, cell block IHC. And some special or related entities include primary mediastinal large B cell lymphoma, plasmablastic lymphoma, primary effusion lymphoma, and human herpes virus 8 associated large B cell lymphoma. We will discuss all these in detail in uh, previous sections. So let's see another variant which is T cell or histiocytic rich variant of DLBCL. We have already discussed in our previous video, but let's revise. This variant is around or mostly less than 10% of DLBCL cases show this variant. Cytologically, large neoplastic B cells are very few, but background show reactive T cells and histiocytes. So, mostly smear appears as a monotonous small cell pattern or polymorphous pattern, and classically large cell pattern is seen very less likely. So, can be mistaken for reactive lymphadenitis or Hodgkin's lymphoma. So, what is the clue? We have to see scattered large atypical B cells to diagnose it as T cell or histiocytic rich variant of DLBCL, and of course we require IHC for confirmation. So this is a T cell rich histiocytic variant of DLBCL where you can identify histiocytes in abundance in this section. This is the showing abundant cytoplasm. So in high power view you can identify these are the histiocytes, and some of the malignant looking cells we have to search for B cell type. So here you can identify small maturing lymphocytes, abundant histiocytes, and some large prominent nucleoli and centroblastic cells in this smear or section. Now let's see primary mediastinal or thymic large B cell lymphoma. So this is a distinct subtype of DLBCL arising from thymic medullary B cells. It shares features with classical Hodgkin's lymphoma, and young adults are mostly affected like 4th to 5th decade. Female predominance, and mostly patient presents with anterior mediastinal bulky mass which shows pressure effect, and prognosis is better than conventional DLBCL. Cytologically, it shows large lymphoid cells. Nuclei are having a size of more than or 5 to 20 times small lymphocytes, prominent nucleoli, irregular and multilobated nuclei. Cytoplasm shows deep basophilic appearance and often vacuolated. Background shows lymphoglandular bodies and mitosis. Now, spatial cytological challenges include when there is presence of sclerosis, which gives hypocellular smear, many damage or naked large cells, or sometimes cell clusters which mimic carcinoma or melanoma. Now, unique pitfall include entrapped thymic epithelial cells which appear as cluster, and it can mimic thymoma and metastatic carcinoma. So, immunophenotype if we see CD19, 20, 22, 79A, 23 BCL6 MUM1, and CD30 is very weak or partial. Negative markers include CD10 and 15 which helps exclude Hodgkin's lymphoma. So, if it is CD79A or CD45 positivity, this is this PMBCL category, and CD15 positive, CD30 strong, it is Hodgkin's lymphoma. And cytogenetics if we show, it lacks classical DLBCL translocation, and it shows 2p amplification which is CREL, and 9p amplification which is JAK2. So key diagnostic message is whenever you see hypocellular mediastinal aspirate, large atypical cells and sclerosis, think PMBCL, not carcinoma. See here, we can see this is the three different types of lymphoma showing HNE, CD20 and CD15 as well as OC2, CD30 marker. So here this is the nodular sclerosis classical Hodgkin's lymphoma. HNE shows here lacunar type of cells. This is mediastinal gray zone lymphoma, and here the category that we are discussing, primary mediastinal B cell lymphoma. So in HNE you can see sclerosis in between this. So this is HNE section. Now look for CD20. So CD20 here it shows positivity which is cytoplasmic, and here CD20 cells are showing positivity, which are the reactive B cells, not the tumor cells. So these are the tumor cells which show CD20 positivity. As well as here, if we see CD15 is negative here, and here it is positive in Hodgkin's lymphoma. So here tumor cells are CD20 positive and CD15 negative, which suggest primary mediastinal B cell lymphoma. Now let's see neoplasms with predominantly plasmablastic cells. So this category includes spectrum of disease like plasmablastic lymphoma, primary effusion lymphoma, plasmablastic lymphoma in human herpes virus 8 associated multicentric Castleman disease, which is called PBL-MCD, and ALK positive diffuse large B cell lymphoma. So these all shows plasmablastic appearance. Now these all share similar morphology, but all differ in clinical setting, viral association and immunophenotype. So let's see what are the viruses associated with this category. So PBL, plasmablastic lymphoma, associated with HIV and EBV. Mostly sites are affected are oral cavities. Then PL, which is effusion lymphoma, primary effusion lymphoma, associated with any of three virus, and this is show serous effusion. This PBL-MCD associated with HHV8 and HIV, mostly nodes are affected, and ALK positive are not associated with all three virus, and mostly nodes are affected. So core morphology, if we see, plasmablastic features we have to appreciate. So first of all, monomorphic large cell pattern, eccentric nucleus, single prominent central nucleolus, moderate cytoplasm, and here it shows minimal chromatin clumping, while plasma cells show chromatin clumping. Second, there is absent or minimal perinuclear HOF. So this is how you can differentiate it from plasma cell. And more prominent appearance in Romanovsky stains. Background shows numerous mitosis, apoptotic bodies and tingible body macrophages. So what are the important differential diagnoses? So here plasmacytoid cells can mimic plasma cell neoplasm like multiple myeloma. Some metastatic carcinoma of breast and urothelial shows sometime plasmacytoid appearance, neuroendocrine carcinoma, melanoma and rhabdoid tumors. So here this is the smear from the primary effusion lymphoma. So effusion, serous effusion shows plasmablastic cells having appearance of plasmacytoid, where you can identify peripherally plushed or eccentric nucleus, irregular nuclear membrane with abundant cytoplasm. Some of the cells show prominent nucleoli. So here again plasmacytoid cells with abundant granular cytoplasm, irregular nuclear membrane and multiple large nucleoli, and some of the cells show cytoplasmic processes. So sometimes you may identify this cannibalistic neoplastic cell. So this is a neoplastic cells and it has engulfed surrounding many neutrophils, and we can see in the cytoplasm of this cell. So this is called cannibalistic appearance. Here also you can identify plasmablastic cells with large nuclei and centrally placed single nucleolus and some macronucleoli also in some of the cells. Here this is associated with human herpes virus 8. So IHC HHV8 positivity we can identify in these neoplastic nuclei. So these are the HHV positive cells of plasma blastoid lymphoma. This is again a smear from bone marrow aspiration where you identify plasmacytoid cells with eccentric nuclei, and here multinucleation can be identified. So this is again a hyperview of multinucleation and plasmacytoid appearance. Here you can identify there is no perinuclear HOF, so that we can identify this is not a normal plasma cell but plasmablastic cells. Here this is the ALK positive lymphoma where you can identify large cells with prominent multinucleation, or you can identify multiple nucleoli and irregular nuclear membrane, bluish nucleoli, and you can identify eosinophils in the background. This is again as a lymph node showing plasma cell myeloma. So here eccentrically placed nuclei with cytoplasm and HOF. So myeloma shows perinuclear HOF in most of the cells, whereas plasmablastic lymphoma will have an absent perinuclear HOF. So immunophenotype, if we see, there is loss of B cell identity with loss of CD45, 20 and PAX5, whereas gain of plasma cell phenotype like CD138, CD38 and CD79 A often retain. If we see immunoglobulin pattern, so IgG is positive in PBL, IgM in PBL MCD, IgN in ALK and DL, ALK positive DLBCL. Spatial markers in primary fusion lymphoma where CD30 positive and EMA positive, where ALK positive DLBCL shows strong cytoplasmic ALK positivity which is granular in C. So this is a differentiating table of primary fusion lymphoma, PBL and plasma cell myeloma. So you go through this table, which is very important to differentiate plasmacytoid appearance of lymphoma and plasma cell myeloma. Now what is the clue? So CD56 if positive, think plasma cell neoplasm, but if it is negative, it is plasmablastic lymphoma. And viral detection, if EBV positive and HHV8, we have to go for this plasmablastic lymphoma. And whenever you find plasmablastic morphology, loss of CD20, positivity of CD138, think plasmablastic lymphoma spectrum, and especially in immunocompromised patient where they may have HIV, HHV8 or EBV association. Now let's see another entity, follicular lymphoma grade 3. So why it is important? Because 1/3 of follicular lymphoma shows grade 3. It is clinically distinct from grade 1 and 2, which is more aggressive and treated like DLBCL and having high recurrence risk. So what is the definition for follicular grade 3 lymphoma? It must have more than 15 centroblasts per high power field, must show at least focal follicular or nodular pattern. Subtypes include grade 3A and 3B. 3A includes centroblast and centrocyte mixture. 3B shows sheets of centroblast and it closely resembles DLBCL and cannot be reliably distinguished from DLBCL on FNAC. So here cells almost disperse, may show follicular aggregates, and frequent mitosis we've seen, which is not seen in grade 1 and 2. Now cell block advantage is there. It shows follicular architecture and CD21 positive follicular dendritic cell meshwork, which helps confirm follicular origin. So cell population include 40 to 60% centroblast, which are transformed cells. Background shows centrocytes and small lymphocytes. These are the centroblast. Here, this is the touch preparation where you can identify grade 3A centroblast appearance, having round nucleus, mostly not cleaved. Open chromatin we can compare with this lymphocytes and multiple nucleoli in some of the cells. Moderate amount of bluish cytoplasm, and here you have to note that size overlap with centrocytes. So don't rely on the size, but you go for the nuclear features and its nucleoli and cytoplasmic appearance. So if we see CD10, BCL2 and MUM1 marker, FL3 shows decrease sensitivity to CD10, BCL2, but MUM1 75% cases show positivity, high Ki67 index compared to FL12. Here T1418 is common associated with follicular lymphoma grade 1 and 2, but it is having less association with follicular grade 3 lymphoma. So key diagnostic pitfall include how to differentiate follicular lymphoma grade 3B with DLBCL. It is indistinguishable from FNAC. We require histology for confirmation. So more than 15 blasts per field, look for follicular lymphoma which is having aggressive look. Now another category is large cell or richer transformation of small lymphocytic lymphoma. So by definition, CLL, SLL is converted or transformed into DLBCL, occurs in 10% cases. Clinically red flag, very important to remember, there is sudden change after indolent course, rapid lymph node enlargement, fever, and if we go for LDH and beta 2 microglobulin, it is increased or high. Background shows typical CLL, SLL small lymphocytes, but more than or equal to 50% cells are having large atypical appearance, mostly centroblastic or immunoblastic. So classically there is dimorphic pattern which include small cells as well as large transformed cells. So this is a smear shows these are the small lymphocytes, but here transform or Richer's transformation gives this enlargement or large cells in this smear. Here also this is a CLL transformed to DLBCL, which is Richer's syndrome. This lymphocytes shows clump chromatin and having soccer ball appearance, while these are the large cells, prominent nucleolus, and here blast cells having cytoplasmic processes, irregular nuclear membrane, and having aggressive look. This transformation is also seen in other lymphomas like follicular lymphoma, mantle cell lymphoma, and mild lymphoma. But if we go for immunophenotype, it retains original clone features and it helps confirm transformation versus de novo lymphomas. So stable CLL, suddenly aggressive look and presence of large cells in background of small cells, which suggests Rich's transformation. It is having poor prognosis. Next category entity is blastoid or large cell variant of mantle cell lymphoma. So by definition, aggressive variant of MCL, it includes blastoid variant and pleomorphic or large cell variant. So blastoid variant resemble lymphoblast, where scant cytoplasm, vesicular chromatin and high NC ratio. So here you can identify, these are the black arrows showing blastoid cells, fine chromatin pattern, visible nucleoli in some of these cells, and centroblastic like pattern. If we see, it is having large cells, features having irregular cleaved nuclei and prominent nucleoli. So whenever you find high Ki67, it suggests more aggressive MCL than classic MCL. Immunophenotype same as conventional MCL, cyclin D1 and CD5 positivity. Cytogenetics show T1114 persistence and highly aggressive course if it is converted to large cell pattern. So mantle cell grows up and become blast-like, think aggressive blastoid variant of MCL. Now peripheral T cell lymphoma, NOS type. Heterogeneous group of mature T cell neoplasm in one-third of cases show large cell predominance. So cytologically, they are large pleomorphic dispersed, irregular convoluted nuclei, coarse chromatin, small but prominent nucleoli, scant pale cytoplasm, binucleation may be seen, and important is background where you find mixed inflammatory milieu, which include lymphocytes, plasma cell, histiocytes, neutrophils and eosinophils, and it gives polymorphous appearance. So diagnostic pitfall include classical Hodgkin's lymphoma. But clue is here more diffuse pleomorphism and irregular nuclei. So here this aspirate shows peripheral T cell lymphoma, and it is extending into perinodal fat. So this is a fat, and you can identify this convoluted nuclei. Coarse chromatin and background shows small lymphocytes. So you can compare very large size of these cells. So ugly irregular cells with mixed background, think PTCL. Now natural killer or T cell lymphoma, more common in Asian population. Classic site include nasal cavity and nasopharynx, which is aggressive and midline destructive lesion. Cytologically very variable, it is from either small to large cell predominance, irregular nuclei, sometimes it is cucumber shaped nuclei. So it is way viva point favorite question for examiner, in which lymphoma you will identify cucumber shaped nuclei, then this is the natural killer T cell lymphoma. Second is granular chromatin, inconspicuous nucleoli and pale cytoplasm. So here unique feature include azurophilic cytoplasmic granules, which is visible in Romanovsky stain, and background it is polymorphous where you identify all the inflammatory cells. So here this is the aspirate showing this NKT cell lymphoma, where cytoplasm show classically granular appearance. So these are the granules in the cytoplasm as well as in the background. Again, large cells, coarse chromatin, vacuolated cytoplasm, and you can compare it with the background cells. Now, immunophenotype, if we see, it shows CD2 positivity, CD56 positivity, which is key marker of this tumor, surface CD3 negativity, but cytoplasmic CD3 positivity is seen. And cytotoxic markers include granzyme B, which is due to granules of the cytoplasm, perforin, and TIA1. So, EBV positivity suggests viral association. So, EBER-ish is a diagnostic requirement. So, when you find CD56 positivity, Epstein-Barr association, nasal mass, cytoplasmic granules, think natural killer T cell lymphoma. Now, another is myeloid granulocytic sarcoma. So, by definition, this is extramedullary tumor of myeloid blast. Another name is chloroma. Cytologically, monotonous large cell pattern. It resembles a myeloblast and can mimic lymphoma. So, we have to uh, see for AML whether it is present or not. So, whenever it is not diagnosed, we have a diagnostic challenge. So, we have to go for MPO, which is myeloperoxidase, which is positive in this granulocytic sarcoma. CD13 and CD33 are positive. So, here myeloid sarcoma or granulocytic sarcoma shows these are the large blastic cells with mitosis, and background shows lymphocytes. So, large cells in node, if we go for MPO positivity, think of myeloid sarcoma. This is important category which is nodal Langerhans cell histiocytosis. So, this is a rare proliferative disorder of Langerhans cells. Synonyms if it is histiocytosis X or eosinophilic granuloma. Predominantly affect children 3 to 6 years of age. Can be, some authors suggest it can be either reactive immune mediated or it can be clonal, which is neoplastic and shows P53 changes. Clinically, mostly skin lesions are there which shows erythematous crusted vesicular pustular rash or salmon colored macular papular rash. Common sites other than skin is bone, especially skull, and in 25% cases lymph node involvement is there, and mostly cervical, then inguinal, axillary and mediastinal nodes are affected. Now, how will you identify Langerhans cells? They are having large size, 3 to 5 times small lymphocyte size, moderate pale blue cytoplasm and mesovacuoles. Nucleus, it is coffee bean or deep grooved, irregular, and grooves may intersect, which is classic finding. Fine chromatin, small visible nucleoli, and background shows eosinophils, which is hallmark but not always present, but hallmark for the diagnosis. Small lymphocyte plasma cell neutrophils are there, and osteoclast type giant cells along with the lymphoglandular bodies are seen. Additionally, if we see eosinophilic granules in the background and capillary fragments may be seen. So, this is nodal involvement by this LCH, where you identify all these Langerhans cells having light blue faint cytoplasm, elongated nucleus, grooved nuclei, and fine chromatin with visible nucleoli. So these are the Langerhans cells, and you can identify intersecting groove. And these are the background which shows eosinophilic granules. Smear background shows eosinophils in abundance, and this is the Langerhans cells. Sometimes you can identify this type of large osteoclast clastic giant cells. These are the Langerhans cells, lymphocytes, granules, eosinophils in the case of Langerhans cell histiocytosis. This is a touch imprint from LCH showing grooved nuclei, beautifully seen here in this HE stain. So these are the Langerhans cells. And diagnostic gold is this granularity in the cytoplasm. It is due to this Bierbeck granules. So these granules are positive for Langerin or CD207 component of these Bierbeck granules, which is ISC positive, along with CD1A positivity and S100 positivity. So these Bierbeck granules are zipper-like, having zipper-like appearance or racket shape appearance. These are the ultrastructural view of these granules, and this is hallmark for Langerhans cells and more sensitive and specific for Langerhans cells than CD1A. So CD207, which is most specifically for this Bierbeck granules. So grooved nuclei, eosinophils in a child's lymph node, think LCH. Whenever you find in skin lesion this type of uh, cells where you find this is coffee bean appearance and mitosis in the some of the cells, and this is osteoclast like giant cell which is multinucleated. It is dermal involvement by Langerhans cell histiocytosis, and this is the CD1A IHC positivity showing membranous as well as cytoplasmic staining. So differential diagnosis, it can mimic Hodgkin's lymphoma or reactive lymphadenitis or histiocytic lesion. So nuclear grooves are present in LCH, but histiocytes are having absence of groove. So key cells in LCH are Langerhans cells, while Hodgkin show RS cells. Nuclei are having grooving, while here a prominent nucleoli are seen in Hodgkin's. Background almost I mix in both, but here in eosinophils are more in number. Markers important CD1530 as you all know in Hodgkin's, while CD1A and Langerins for Bierbeck granules in this LCH. Now let's see another entity, dendritic cell neoplasm. It is rare, arising from antigen presenting dendritic cells, can involve lymph node as well as extranodal sites. Highly variable cytology showing monotonous large cells which mimic lymphoma. So two types from the origin of the cells like follicular dendritic cell sarcoma and interdigitating dendritic cell sarcoma. So this is most common, FDCS is most common, often involve nodes like cervical and mediastinal. This interdigitating is more aggressive and it is arising from the T cell zone. So general pattern, as this is large atypical cells, can be spindle over or epithelioid type. Nuclei show irregular nuclear contour, vesicular chromatin, prominent nucleoli, and background shows admixture of lymphocytes. Sometimes whirling pattern, which is diagnostic on H&E section. Immunophenotype, if we see, these FDCs are positive for 21, 30, 23 and 35, whereas S100 positivity by IDCS and CD45 is variable. So what are the diagnostic pitfall? Can mimic with DLBCL or metastatic carcinoma or melanoma, because it also having large atypical cells with dispersed cell pattern. But for that we require immunophenotype. So if large cells don't fit lymphoma and shows dendritic markers positivity, think dendritic cell tumor. So in this histo section we can identify these are the spindle cell neoplastic nest are seen with peripheral cuffing of lymphocytes. See, you can identify these are the neoplastic spindle cells. These are the follicular dendritic cell sarcoma. In high power view, you can identify these are the cells, neoplastic, and this nest are having cuffing with the small lymphocytes. So, there is cuff of small lymphocytes surrounding this uh, neoplastic spindle cells, as well as you can identify these blood vessels. So this is the classic picture of follicular dendritic cell sarcoma on H&E section. Now if we go for IHC, interdigitating dendritic cell sarcoma shows S100 positivity, and here in this section you can identify these are the neoplastic cells with oval elongated nuclei, eosinophilic abundant cytoplasm and indistinct cell border. So S100 positivity, CD21 is negative, but these are the retained germinal center which show positivity by the follicular dendritic cells. So this is normal, not tumor. Clusterin also negative, and Langerin which is uh, seen in this negativity in this interdigitating dendritic cell sarcoma. Now after all these lymphomas and hematomatous lymphomatoid variant, let's see some metastatic malignancies which shows this large uh, pattern of lymphoma, which include metastatic carcinoma, melanoma, sarcoma and seminoma. So whenever you find metastasis which can mimic lymphoma, when the cells are poorly differentiated and having discohesive and dispersed pattern, and many tumor cells are present showing dispersed pattern and few lymphocytes in background. So how will you identify whether it is metastatic or lymphoma? So here we have to see the cells which is larger than lymphoma cells with moderate abundant cytoplasm, vacuoles in the cytoplasm which is of mostly mucin in adenocarcinoma, having large prominent vacuoles and present in both PAP and Romanovsky stain. Small clusters even seen in dyspersmia. So careful search of clusters will guide us to metastatic tumor. So whenever we find nuclear molding and naked nuclei, we have to go for IHC marker. Like cytokeratin mostly seen in carcinoma positivity. Site specific markers we require like for lung and thyroid TTF1, prostate PSA and breast carcinoma ER and BRST2. So here mimickers include poorly differentiated carcinoma, neuroendocrine, sinonasal undifferentiated carcinoma, and nasopharyngeal carcinoma, which is lymphoepithelioma type. So what is the clue? Any cohesion or mucin vacuoles, if you identify, think carcinoma before lymphoma. So here this is the metastasis from undifferentiated nasopharyngeal carcinoma or lymphoepithelioma, which is sminky type, which shows large cells which intermingled with these lymphocytes and having eccentric nucleus, vacuolated cytoplasm, nucleus having smooth outline and prominent central angulated nuclei. So this is in background showing eosinophils and neutrophils, lymphocytes along with this tumor. So this is a case of undifferentiated nasopharyngeal carcinoma metastasis. This is again a metastatic adenocarcinoma where mediastinal lymph node shows loosely cohesive large cells with uh, moderate amount of cytoplasm. Some of these cells show naked nuclei and multiple prominent nucleoli. This is again a pulmonary adenocarcinoma metastasis to lymph node where you can identify dispersed pleomorphic large cells with abundant cytoplasm which is vacuolated. Again, this is the anaplastic thyroid carcinoma metastasis to lymph node where you can identify these large bizarre cells with prominent nucleoli in this pap smear. Now, second is metastatic melanoma. It shows large pleomorphic cells, maybe having plasmacytoid appearance or epithelioid appearance. So, diagnostic clue is melanin pigment in either tumor cells or macrophages or melanophages. But what is the pitfall? Pigment may be absent. So, on the basis of only pigment, we cannot identify malignant melanoma. So, what we have to go for? Whenever we find bizarre pleomorphic pigment, suspect melanoma and go for IHC. So, here again, this is a case of alveolar rhabdomyosarcoma where you can identify these are the bizarre or large cells with vacuolated cytoplasm which resembles lymphoid or lymphoma. And here also this is a smear from malignant melanoma where you can identify malignant melanoma cells with pigmentation in the cytoplasm of melanophage. So this is the pigmentation in the melanophage and these are the large cells suggestive of malignant melanoma. Here also you can identify these are the pigment containing melanophages, prominent macronucleoli or it is called pseudo inclusion and fine pigmentation in some of the cells, some cells binucleation. So these are all features of malignant melanoma. So see here you can identify pigmented cells with pseudo inclusion and cell discohesiveness. Now metastatic sarcoma, which is rare in lymphoid tissue, but if we find it is spindle cell or pleomorphic type, so it is showing small round blue cell pattern, but it may appear as a monotonous large cell round pattern. So round cell tumor mimic lymphoma like rhabdomyosarcoma, neuroblastoma or Ewing sarcoma or PNET. So what is the clue? When you think sarcoma in young patient, look for atypical round cells and if non-lymphoid markers are positive, we can have a metastatic sarcoma in diagnosis. Now, this is a smear showing neuroblastoma metastasis to lymph node where you can identify this type of dispersed large cells with round nucleus, moderate amount of cytoplasm, but characteristic feature is salt and pepper like chromatin. So some light and dark chromatin clumping is there. So you can compare it with this salt and pepper appearance, which is the hallmark for neuroblastoma. Ewing sarcoma, where these are the blastic appearance of these dispersed large cells and having small lymphocytes in the background. We must require IHC for confirmation. Now, metastatic seminoma or dysgerminoma. So, clinically it present as a retroperitoneal or mediastinal nodes in young adult. Occult primary can be possible, so we have to go for markers. Cytologically, if we see large cells with clear cytoplasm which contains glycogen and cytoplasm is fragile, so naked nuclei are commonly seen. Nuclei are round, irregular, prominent, and central nucleolus is present. Background shows lymphocytes. Sometimes granulomas and histiocytes may be present. But what is the signature feature? Tigroid background, where you find fine lace-like pattern which mostly or only seen in Romanovsky stain due to glycogen-rich cytoplasm, and mostly in 50% of cases you will identify this feature. And immunophenotype important, FLAP1, OCT3, 4 positivity, CD117 and D240 positivity. So what is the clue? Clear cells, lymphocytes, tigroid backgrounds, look for seminoma. So here this is the nodal metastasis from seminoma showing very large cells and admixed with these lymphocytes. And these cells show smooth contour, open chromatin, prominent central nucleoli, this is the pap stain, and clear cytoplasm. So this is a classic case of this nodal metastasis of seminoma. And what is tigroid background? So here you can identify this background in the Giemsa stain. So this is the comparable to the tiger skin. So this is called tigroid background. So what is the characteristic features of seminoma? Moderate to highly cellular smear, poor cohesiveness, stripped nuclei without cytoplasm, large single cells with central vesicular nucleoli, nucleus and prominent nucleoli, tigroid background, sometimes epithelioid cells and granuloma can be seen, and multinucleated histiocytic cells with lymphocytes rarely seen in atypical forms, and necrosis is not characteristic. So this is how you can identify all the metastatic lesions in lymph node. So these are some of the ultra master table include B cell lymphomas and its entity, what are the key cytological clues, background and key markers and pitfall, along with the T cell lymphomas as well as hematolymphoid uh, patterns and metastatic tumors. So go through this table and remember, monotonous large cells don't give the diagnosis, but the pattern and markers do. So save this, revise it, and you will never miss the answer in your exams or practice, and you can have easy diagnosis of lymphoma on the basis of pattern. So here you can identify now monotonous small, monotonous intermediate and monotonous large cell pattern on the FNSC smear, and you can differential diagnose your lymphoma. So in next topic we will discuss the pleomorphic cell pattern. So keep watching, and yes, if you haven't yet subscribed this channel, then please like, share and subscribe this channel for more such videos. Thank you.